here it's pretty much children in kindergarten, not yet in grade one. And so by age three, a child representational world has begun to be occupied by composites of many things. So now their verbal, their fine and gross motor skills are developed. Their language is, up to speed. Um, Even their social development should be also up to speed. So this representational world becomes a reference for then processing biopsychosocial stimuli. When you work in mental health, after we assess a patient, we do something called a formulation. The formulation is how do we understand this person? Okay. Every depressed patient is going to have to meet DSM-5 criteria to call them having a major depressive episode or disorder. However, every person has many, almost entirely different parameters in terms of their psychological makeup, their social setup, their genetic background. So their biopsychosocial aspects of that person are going to be different, although the presenting problem is a major depressive disorder. So when we do a biopsychosocial understanding of people, that way we can sort of understand them in a better way so that we can better provide help. So if somebody has a depressive disorder and there's a genetic basis to it, but on a psychosocial aspect, they are a single person, they're unemployed, they don't have any social support. On top of their depressive disorder, they have a substance use disorder. So here, the outcome of this person would be very different than somebody with the same presenting mood symptoms, but who is employed, has a good family structure, a lot of psychosocial support, no other comorbid disorders. So the outcome is very different, although they both are presenting with the same disorder. So it's really important that when we assess people, we look at their biopsychosocial grid. So how do, like in terms of just processing the biopsychosocial stimuli? So here, the child receives a stimulus. So there's the reception of stimuli from the environment through senses, whether it's something they hear or see or touch or smell. And according to that stimulus, there's going to be a generation of an initial emotional response to that stimulus. Then there's going to be a processing of the mental contents. Okay, then that then will trigger an output. So they smelled something that was nice, and how do they respond to that by actions or things that they say? Or it was they touched something that was hot. How was the response in terms of things that they say or do? So every stimulus that we receive triggers an emotional response, which then in turn affects our behavior. But also then there's going to be an activation of a capacity of observation in relationships with people, with the world, an activation of capacity for self-reflection. And then there's going to be a construction of new representations that will involve the final output responses. And the response or lack of from others. So this is kind of like an overview of how behaviors occur. What makes you say or respond to something today differently from the same event tomorrow? Because again, your mental state today is going to be different from tomorrow, was different from yesterday, and the intensity of your responses will also differ. So what are the major developmental tasks of early childhood? So kids from age 3 to 6, they would have developed a gender identity. So by age 3, they would know if they're a girl or a boy. With gender identity comes gender role, which is a different thing. So I identify as a boy or as a girl, and then what is the role of a girl, role of a boy. Um, and so, how do I identify within that? And then an autonomous and valued identity. So, I am separate from my mother, I'm separate from my siblings. And so, when you look at children with autism, this does not happen. Children with developmental delay, depending on severity of intellectual disability, these do not happen. So they also have experiences that enable them to construct the following self-representations. So we look at peer identity. So in a group, how does this toddler, 3 to 4 or 5 year old, behave? You know, how are they a leader in that group? Are they a follower? Are they a pleaser? So how does that child behave within a group setting? It's really interesting how like moms will tell you that they start to discover their children once they are off to school because now they're interacting with different people, and so maybe at home, this child is loud and obnoxious, or, uh, you know, um, um, sort of takes things from other people in the house, whereas maybe at school, they could be a completely different person within their peer group. When we look at conscience, again, it's very relative. You know, a 3 year old sense of right, wrong, morals, whatnot is obviously going to be at a different level from a 6 year old, from a 10 year old. So it's that beginning of the moral construct. And then when we look at sexual identity, I mean, what's meant for by it is, again, coming from a gender identity, because at the age of 3, 4, pre-pubertal children, there aren't any hormonal influences to affect, to start to have any kind of input into that. So, what are the functions of a social environment? A social environment will foster healthy narcissism and an ability to delay gratification. The development of a true self. Remember when we talked about Bowlby, true self, false self? So here, the awareness of a child aspirations to be perfect, like I told you before, it's really essential for kids, young ones, to feel like, when their parent looks at them, that they're the apple of their eye, that they're the most important being, and for a sense of like that the universe kind of revolves around them. So it's healthy narcissism. Also allowing the child to periodically view themselves as perfect and view their parents as perfect. It's really important for kids to have that view of their parent, like they become their role model. So, if there is a marital conflict, for example, and mom or dad tend to put the other parent, like one parent puts the other one down, um, you know, kind of portraying them as imperfect or with many flaws, it doesn't really help the child. Okay. So even if, I mean, we advise parents, even if they're in the middle of whatever conflict, whatever, don't put your partner down in front of your child, because it doesn't make, it just affects how they will internalize that parent. So it's important for kids to view themselves as perfect, to view their parents as perfect. What about sort of their innate needs, their early genital needs? So around the age 3, kids will focus on their genitals in the sense that out of discovery. A 3 year old, if mom has a new baby who's of a different gender, will pick up on the difference in appearance, and they'll ask, like, what is that? Or how come I don't have that, for example. And so toddlers are really interested in exploring their bodies, belly button, ears, nose. And so again, accidents happen at this time where you find that children will in sort of insert like Cheerios, little Oreo cookies into, ears or belly buttons. And sometimes, they will manipulate the genital area out of, again, I would say accidental. I get consults sometimes from even from kindergartens calling to ask, how do you manage or how do you deal with, if children are, touching themselves. So again, we've talked about this. The best thing to do is, not to make a big fuss of it and to kind of just distract the child because it's not, there are no hormones involved here. Sometimes kids, um, again, when I assess a child who engages in touching themselves often, we assess environment first because you want to make sure that this child was never exposed to inappropriate touching, or that they had not visually seen things that are inappropriate. Sometimes, again, kids are in a very non-stimulated environment. And so if accidentally they come across touching themselves, and so they may engage in it, just like when kids suck their thumb out of boredom, it becomes something that they do as a habit. And then when the parent reacts negatively by either yelling or scolding, or it becomes an attention-seeking behavior. And so they may engage in it more to get parents' attention rather than, it being any way pleasurable sort of behavior. Then we have a lot of physical abilities in this age, 3 to 5. There's growth spurt, increased body weight size, and motor coordination. By age 3, they're able to get on a tricycle. Kids learn how to swim. So there's that part of the development, the motor development. What about their cognitive abilities? So again, from 3 to 6, they start to develop reality-based thinking, and it really depends on the type of parent that the toddler has. So you have a parent who is really has the ability to mentalize. And so they use empathy, intuition, they reflect on biopsychosocial stimuli. So they reflect on, behaviors that children have based on, environmental inputs. So we're going to talk about this also in detail when we look at assessment of behavior. But I remember I had a patient who would come home and was extremely aggressive if they didn't find their lunch prepared. This was like a 6 or 6 year old or 5 year old, and they would actually get into like this rage until there was food. So we were trying to work around, why this child, the amount of rage. So one of the things was, I mean, parents initially were doing was, punishment, time out. And so I like to work backwards. I don't like to kind of manage a behavior at face value. So yes, they're aggressive, but it's really important to understand why, how, why, where. And so when we worked with this kid, working backwards, we found out that they actually have an issue with their insulin where they become hypoglycemic. The insulin level was really up and down. And so part of it was, getting the proper medical attention, making sure that this child had frequent snacks so that they don't have drops in their blood sugar. And so that was how we managed it versus giving them time out or punishing them, or making them feel bad about themselves. So it's really important to understand this biopsychosocial environment. And then you have parents who don't have that capacity, and they have a deficiency in awareness regarding what's going on in their minds and the minds of their children. I'm seeing a 17-year-old girl. I've known her for probably a good 6 or 7 years. And yesterday in our session, she was saying exactly what highlights this point, which is her relationship with her mother, where all her life she just, her mother was never able to understand her true needs, never really was able to understand her thought process, despite, this girl's attempts to, explain herself, explain her needs. Um, and so she has the parent who's just, completely unaware. Um, and so this young woman is struggling with major issues related to her um, identity, so many conflicts in her mind related to morals, beliefs. So, she's in a very bad place right now. We're still trying to kind of go over, the conflicts that she has. We talk about theory of mind, and that's usually established by around age 4.5, and this is when they kind of come to the realization that other people have thoughts that are different from their own. Remember when I showed you the video of that young boy where the interviewer was sitting across from him and was asking him, what is it that he sees from his side? And then when they switch, and she asked him again, and for him, it had to be that she saw what he saw because, it's like they're not able to have that understanding that other people could have something that's different from them. And so by age 4.5, they start to have that realization. They start to be more aware of the relationship between internal and external realities. Um, and then they use pretend play. And usually when they are pretending, they know it's pretend. Like that video of that girl and her sister, and so the concept of pretend play is something that they are very well aware that it is pretend. It's not real. So by 4.5, that theory of mind is well established. So when we look at executive functions, so executive functions are pretty much frontal lobe type things. So, brushing teeth, getting dressed, things that are learned, riding a bike, knowing how to swim, making a sandwich. So it's a learned thing or learned behavior where when you do it, it becomes a process. It's a procedure that you do and not much thought goes into it. So kids who have issues with executive function and the sort of the highlight of that is children with ADHD, where there is an executive function problem. They're not able to do the daily things that other normal children do without prompting. Okay, so kids with ADHD are going to require prompting because their executive functions are not quite intact. We're going to talk about temperament because temperament is so essential in understanding children. And so temperament is not like uh, temper, when someone has a bad temper. Temperament is your like your character traits. And this is what makes every person different from the other, is their temperamental characteristics. So there was two psychiatrists, Chess and Thomas, who identified sort of 9 parameters uh, and of temperamental characteristics. And it's the mix and match of these that makes a person sort of who they are in terms of their temperament. And so the sort of parameters are activity level. So you have sort of ends of spectrum and within normal, sort of an in between. So ends of spectrum are kids who are, pretty active. And on the other end are kids who are kind of slow. And again, this is not a disorder. This is a personality or like a character trait. And so we say that some people are just like on fire, like they're just up and about and sort of can't sit. And we're not saying that someone has ADHD. We're saying that their level of activity is on the higher end. And you have some people who are just generally like slow. So they're going to be slow eaters. They kind of move slow. If the world falls apart, they're just extremely chill. So the activity level is different. Rhythmicity, we look at, like their feeding, they're sleeping, so they're kind of their biological clock, if you will. Some kids are poor sleepers, some kids are sleep well, some kids, when it's time to eat, they can't tolerate hunger. And so that's kind of a description of how organized is their clock versus some kids where they can if their eating is delayed, it's fine. Their sleep again is not on the clock, so that's what rhythmicity is. Approach or withdrawal talks about exposure to new situations. So in a new situation, does this child kind of go out there and explore, or does this child kind of freeze and sit next to their parent and sort of is more withdrawn? Um, the adaptability to change is being flexible. Some kids, if you put them wherever, they'll sleep. Some kids, if it's not in their bed, they won't sleep. They are not flexible, or some that are extremely flexible. So how adaptable are they? The threshold of responsiveness or sensitivity is just a reflection of how some children are extremely overreactive, anger outbursts, tearful, crying, whereas some kids have a much higher threshold to, for example, change. So moms will tell you, my child is like is over. They're extremely dramatic. So this is somebody who has a very low threshold, or is extremely sensitive. And that goes into the intensity of reaction. So if somebody's threshold is extremely low, then their intensity of reaction is going to be quite high. And if their threshold is really high, and tolerant, then their intensity is quite on the lower side. Then we have mood. And so that again depends on, some children, their mood is extremely reactive, whereas some kids are a lot more mellow. Degree of distractibility in terms of when given tasks, and so ties into the last one, which is persistence in the face of obstacles. So an example would be, if a child is given a puzzle or blocks, are they able to, not be distracted and follow through despite obstacles, meaning, they're not sure how to fit it or how to finish it. So you could get a child who kind of initially tries, but, gives up or gets distracted and doesn't follow through. So taking all of those parameters into consideration, they've kind of summarized it into types of temperamental variations, where children are categorized as being ones with easy temperament, which are the most easy to deal with because they're flexible, they're not extremely reactive, their mood is generally stable. So moms will tell you, like, this child was just really easy growing up. I never struggled with them, very smooth. On the other end, you have kids that are really difficult, where moms, encounter problems like, this child was poor sleeper, was colicky. If they're not fed, they're cranky, a very picky eater, extremely reactive, extremely sensitive. So that makes this a very difficult child. And when we look at difficulty here, we assess a goodness of fit. So, like, yes, my yesterday's patient, so she's the eldest of three. And I see her, but I also see her younger sister as well, who has OCD. And I see, it's the same mother, okay? But I see how with the eldest, it's not a good fit, if you will. They're always clashing. They're never on the same page. age. Yes, the patient is a lot more difficult and her temperament is not an easy one compared to the youngest, who is a very easy child, and there's a goodness of fit. So mom fits and the youngest have a really good fit. They're in sync. And so it's very smooth. And sort of when I talk to the mom, she always compares. She's like, why is it that I struggle with the eldest? And with this young one, she understands me, I understand her. So um, even if you have, you know, again, it's the same genetics, it's the same mother, same father, but they may not be a good fit. Okay. And I tell parents, your five fingers are not the same and they're on your hand. So your children are not going to be the same. So one size does not fit all. So parenting has to be dynamic because you cannot apply the same to all. Then you have a slow to warm up child, and this is a child who's kind of timid. And the best way to kind of describe them is, or picture them, is imagine if you're taking something out of the freezer and you want it to defrost, okay? So that's exactly what these kids are. So it takes them time to kind of uh, defrost, if you will, in a new situation. So they'll enter the situation, they'll be, kind of more withdrawn, uh, and they will scan the environment, and then they will assess for hazard, okay? And then they will sort of eventually leave mom's side, but it'll always be the end of the party. So it takes them time to warm up to new situations. And so somebody could say, well, is this like a precursor to, a child who's going to have separation anxiety or some form of anxiety disorder? And again, the link is not clear, but the best way to deal with these children, the slow to warm up, is to, you know, expose them to different and new situations constantly. So when I ask about like the social circle for a slow to warm up child, it's usually very limited. And usually, you could find that parents, one or maybe both of parents, are on the less social side. So yesterday in the clinic, I was seeing this 8-year-old, 7-year-old who was referred for the assessment of depression. And so he actually met criteria for depression. But he also has a slow to warm up temperament. So not the most social kid. And so a lot of his temperamental characters, you know, it's just he is the same child, but on top of that, like on top of, not really being very social, not really interested, or it takes time to, adjust to new situations. We were encountering now a recent onset of irritability and sadness and death wishes. Okay. So it's really important. And to again, when I asked the mom about herself, so she herself kind of identified with him as being similar. She's also a very slow to warm up type of person. When we look at emotions, generally emotions will govern emotional expression. Okay, there are rules that will govern emotional expression. We have a various range and shade of emotions, obviously. So regulating anxiety, it becomes important and more prominent between age 4 to 5. It's important that they recognize when they're anxious and that they can discriminate what they're anxious about. Okay, so it again depends on the level of intellect, the level of language, how much language does this child have, how expressive they are. And again, at age 4 to 5, some kids can tell you what they're afraid of. Some kids can tell you what makes them worried, at a very simplistically. And then emotions can be facilitators of social adaptation, so achieving self-regulation and social adaptation. Looking at language, again, in summary, by age 3, they use speech, thought, and behaviors to achieve a belief in their own ability to anticipate and predict events. They could remember things from the past at the age of 3, but also sometimes it's reconstructive. They can generate a fantasy based on a recalled memory and then reconstruct a memory. So if you're talking to a 3-year-old or 4-year-old, sometimes it's some fantastic things that they'll tell you. And again, we don't like to say that this, 4-year-old is lying. Um, because again, what is it that they're reconstructing? What is the objective of that reconstruction? Are they feeling lonely? Are they feeling sad? So again, nothing is what it looks like until you actually, assess it thoroughly. The development of the self and object relations. So, when we look at sexual identity, which is established by age 3, and so what it is this unquestioned, unthinking conviction that they are male or female. So it's without a doubt. So they know for a fact that I am a boy, I am a girl. This is by age 3. Um, some things, again, like we said, they could be curious about their genitals, and this is a time to teach them about privacy, at the age of 3, because again, they're going to be off to nursery or daycare, is when moms usually start to tell their children about, private parts and that nobody should see or touch. Um, Body damage, anxiety. Remember when we talked about how, in terms of cognition, they're quite concrete. And so again, when children, if they are like touching themselves, and so some parents will say like, if you don't do this, if you don't stop, then you're going to get really sick or is going to happen to you. So they're very concrete, and so they start to have this anxiety that something's gonna affect their body. Exhibitionism is sometimes, observed in nurseries where, kids will like pull down pants or pull up dresses, and it's partly part of playing, not exhibitionism as would be seen in, an adult with some, disorder. There's a development of peer identity and the need for peer interaction and learning to share. The superego, we're going to talk about that, inshallah, after when we go back in person after Eid, when we talk about Freud. So the superego, simplistically, is the feeling to have that part of you that kind of keeps you in check, if you will. So a feeling of guilt is experienced. How does it even start? First of all, they need to know the difference between right and wrong behaviors. So someone must have taught them that that's right and that's wrong. Because if you don't teach them right and wrong, then this super ego is never going to develop. Then they believe they have a choice between the two behaviors. Okay, so they know what's right and wrong. They did something that's wrong. Okay, and then for them to acknowledge that they made a bad choice. And so, what's really a better way of parenting is once your 3 or 4-year-old does something wrong, instead of punishing them. Okay, um, so I don't like calling it naughty chair. I like to call it the thinking chair. So a parent who will tell their child, I want you to go and sit on that thinking chair and, think about what you did, and then come and tell me why you think it was wrong or not. So you want them to actually reflect on their behavior, their choices, and then acknowledge that was the wrong behavior, because that's really how they're going to learn. Now, superego anxiety comes from excessive building of guilt. Like if you raise a child to kind of feel guilty about, anything and everything, then we have what's called superego anxiety. Important also at this point with the superego is to foster self-responsibility and self-love. It's really important to be accountable, that things happen for a reason. And, what was my input and where's my responsibility in what happened? So adaptational capabilities, we talk about repression, okay, and we're going to talk about repression in more detail when we talk about in the next couple of lectures. So it's an automatic unconscious mental process that borrows from conscious awareness, things that generate disapproval, memories that are unpleasant. Okay, so they say it emerges, but then becomes really prominent. So it starts to emerge at 18 months, this concept or this sort of unconscious mental process. And then by age 3, it is more prominent. And so we talk about repressed memories. And so these are things that have happened to us that are really in the back of our mind. So repression helps kids adapt. Okay, but it's overused usually to repress traumatic experiences. And so people who've endured trauma as younger, in their younger years, and if these are all repressed, okay, so there's no memory of actual abuse. So they were like, inappropriately touched or some kind of trauma happened to them, but they don't remember it, okay? But then what happens is it kind of plays out in interpersonal relationships later on in their life. So, for example, they come to therapy because they just feel uncomfortable in friendships or in intimate relationships, and they're trying to figure out why. Why is it that I feel the way that I do? And then oftentimes with therapy and over time, all these like repressed memories can come to surface. And we're going to talk about that in sort of in lectures to come. So I'm going to move on to the following lecture. All right, so moving on to late childhood, adolescence, adulthood, old age, death, and bereavement. So 6 to 12 years, that's intermediate, like it's elementary, elementary school, grade 1 to 6. Major developmental tasks here is more of the peer identity and social identity. So by age 7 years, they have an autonomous identity, they have a gender identity. I mean, their sexual identity here again is, you know, sometimes it's about like, let's say, again, I remember a mom, talking to me about her 6-year-old boy who has a crush on his friend at school. He likes her, he brings her flowers. And so it's kind of the beginning of that, like a preference, if you will. And then peer identity, as we talked about, is like how do you function within a group? The development of sort of innate needs. So physiological needs are really related to bodily regulation and physical survival. So here, they're exploring the social environment, attachment and emotionally pleasurable interactions, friends, teachers, family, emotionally pleasurable sensory sexual stimulation, gratification. Again, depending on, kids like we said earlier, who may touch themselves and sort of how do you deal with that? But also, kids who have the habit of sucking their thumb and how that helps them to kind of calm down. The physical capabilities at this age, again, it's more about frontal lobe maturation, um, all these major nerve tract myelination, so more motor control, fine motor, visual motor skills. So from the age of 6 onwards, engagement in different types of sports, When we look at temporospatial skills and how kids manipulate, like in terms of when they play video games and their ability to coordinate, and the visual motor skills is, how do they manage holding a pencil or pen? How do they color? So these are like major tasks that are become more enhanced in that time frame. Now, with looking at their cognitive skills, okay, so we talked about Piaget and how he covers this phase of life in terms of their cognition. So understanding others' perspectives, complex categories, logical reasoning, like we said, reversibility, comparing past and present, conservation of mass and number. And development, again, more verbal language abilities, gender and sexual identity. The superego is like, again, what governs their sort of moral um, uh, understandings and behaviors, and more development of emotions. Um, Adolescence, from age 12 to 19. And so again, it's finishing school and entering university for many, or joining the workforce for some. So this is marked by profound biological, psychological, social, developmental changes. It's variable in the age of onset, length, and rate of growth and sexual development. So it's the Piaget's formal operations, and it's divided into three: early, middle, and late. And so puberty being different from adolescence, because puberty is physiological, whereas adolescence is more psychological. And puberty, as you know, is all this hormonal hypothalamic, pituitary, adrenal, gonadal axes, development of primary, secondary sexual characteristics, and then you can have how precocious or delays in maturation impact psychological well-being. So if you have precocious puberty, a 9-year-old girl who has her period in grade 4 when nobody else has their period, and if she's going to need to cover, and so how does that, and again, for girls, it becomes something that a lot of them could be worried about, if they get their period and nobody else has. Delays, again, everybody's got a growth spurt and they're, adding on centimeters, whereas this child is not. And so everybody's much taller. So how does that affect their well-being? With onset of puberty could be earlier in girls than it is in boys. Psychosexual development, cognitive and personality development. So how does the pattern of thinking change to have a secure sense of self? Now with identity diffusion, it's a really interesting concept because you would want, and we're going to talk about that with Freud as well, you would want somebody in their adolescence to be to have a good sense of who they are, in terms of like their thoughts, their beliefs, and not to be somebody who's confused, because confusion, if they're kind of lost, then they tend to maybe join the wrong peer group, and then you have that negative influence. Because they don't know who they are. And so yesterday, my patient was talking also about that. She was like growing up, it bothered her when her friends would tell her that she was easily influenced by people around her, and she was so adamant that she was not. But yesterday, she was like, I regret to admit that I am easily influenced. Like it's like a wave can take me this way, a wave can take me that way. I don't know who I am. I don't know what I want. And so she's in that stage of just completely confused, and her identity is just all over the place. And so it's a very dangerous place to be because, again, you could be easily led in any direction. And so peer groups, kind of your sensory input, like in social media, what are you listening to, affects who you are. Negativism is something that we see commonly in teenagers, and that's like, when they'll tell you like, oh, the world is against me, everything's just not right, I hate life. So if any of you have, teenage siblings, I'm sure it's something that is not news to you. The development of morals, again, it's more about conformity. So morality is a conformity to shared standards, rights, and duties. So it's not that they develop morals at this age. We talked about morality starting from a younger age, and then it just becomes more complex, more abstract, if you will. So morals. So morality is a conformity to a shared standards, rights, and duties. So you need to have something you need to have these shared standards, rights, and duties. So it means that, you need to be in an environment where these things are taught, like someone is telling you right and wrong, values, so you need to have that in your environment, okay? But there are kind of three levels of morality, if you will. How does it actually develop? So you have a pre-conventional morality, where here the determining factors are punishment and obedience to parents. Okay, so at an earlier stage, it's really about I don't want to do something that's going to upset my parents so that I don't get punished. So I'm not going to steal. I'm not going to lie. Okay, because I know it's wrong. But what defers me from doing anything wrong is because I'm afraid of punishment. And so here kids are again more concrete. Now, the next is a morality of conventional rule conformity, where children conform to gain the approval. Okay, so here I'm afraid of punishment, but then I'm starting to do things because I want approval. Then you move on to the last, which is where they comply with rules on the basis of ethical principles. So morality of self-accepted moral principles. So now it becomes almost like imprinted in their system. So it's not like they're doing it for anyone or they're afraid of anyone. We kind of conform because they've become ethical principles that we follow. Okay. And so when you're older, and you don't do something wrong, and it's not because of anyone, but obviously then we start to do things because of haram, because of halal, because of Allah. Okay, so that kind of comes here, because a 3-year-old is not going to understand haram and halal. It's too abstract. Okay, but as we get older, these become replaced by, other more like other concepts that then govern our behavior. So yesterday, again, my patient was telling me something really interesting. So she was saying that one of the things that used to, not one, the thing that used to prevent her from doing wrong things was in haram or halal. And what's scaring her now is that that's not how she thinks. Her thoughts are now that it's not about haram or halal, but it's more about, that something dangerous would happen to her. So it's more about fear for herself. So she's also concerned about that shift in her sort of, let's say, ethical constructs. So that's why she's even more worried about herself. So adulthood, it's the longest phase of human life, and it's divided into early, middle, or late. And the early is, again, age 20 to 40. And it's the peak of biological development, assumption of major social roles. So here people are, graduating university, going on to higher studies, or, they're working, employment. So it's a very dynamic time of life, the resolution of adolescent crises, where, teenagers feel like they're lost, but around age 20, people need to have an understanding of what am I, who am I, where am I, that kind of thing. So it's a transitional period, graduating from high school, getting a job or entering college, exploring occupation, beginning of intimate relationships that, again, are more solid than, just things that are in high school or as younger people. Developmental tasks of occupation, marriage. In the 30s, preoccupation with achieving authority, independence, being self-sufficient, financially independent. And so this transition may be smooth or it could be associated with marital problems, job changes, or psychiatric symptoms. So a lot of challenges within that 20-year period. People could be vulnerable. And so if someone adjusts easily, then you're someone who's not as vulnerable. Um, Occupation, again, is dictated by your socioeconomic status, gender, and race. Unfortunately, that still exists, where, depending on gender, depending on race, you can be higher up in the chain or at the very bottom. Looking at economic status of women and how that's changed over time. Considering unemployment and what are its negative outcomes. Marriage, its success or lack of, parenthood, being, again, looking at single parent families. So many dynamic things happening during this time period. And again, the impact of each on a person. And again, keep in mind, you can have two people going through the exact same, life struggles, but outcome depends on so many other variables. Middle adulthood, so we're looking at 40 to 60. So 40 is the noon of life, according to Carl Jung. Terminating early adulthood involves considering how the past has gone, sense of satisfaction, and how the future is going to be. Gaps between aspiration and achievement. So here could be, a time when people can have depression because, what they had built their life out to be and what it actually is, and, depending on that gap. So things like disappointment, frustration, children leaving home, and parents starting to redefine their roles. So a lot of parents, couples discover each other after uh, their children, leave home, going off to university, and so now they're kind of left with each other. And maybe over the years, where their children are growing up, they've not invested in each other as a couple. And so, coming to realize, who's this person that I married and things like that. Also, gender role change in how that affects relationships. So, for example, he could have been the major bread earner, but he's laid off work and now she has to be working, or he's ill and is unable to work and now she has to be the one that earns the money. And how does that affect a relationship? So you see, like, the amount of things that could affect a person is just incredibly diverse. Um, so developmental tasks here are things like aging and bodily changes, taking like accomplishments, setting goals for future, reassessing commitments. How do you use power responsibly if you're like the CEO of a company? Are you fair? Are you not? And also, at the same time, dealing with your own parents' illnesses or, God forbid, death. So, Valen talks about correlates of well-being, that there's a strong correlation between physical and emotional well-being, where people with poor psychological adjustment during college have high incidence of physical illness in middle age, and that general stability at home accounts for a well-adjusted adult, that close sibling relationships in college year account for well-being in middle age. Sexuality also a major issue in middle life. Bodily changes that prompt cosmetic surgery, menopause, and how does that affect self-image? And does that prompt more cosmetic surgery? With men, again, the crisis may be mild or severe depending on, because again, with men, there's no clear demarcation of as it is in women, where menopause is a very impacts quite strongly, and at a physical level, but also at a psychological level as well. Midlife crises. So that would occur more so if someone comes from a family where there's a lot of parental discord, where their parents were anxious, or their parents were impulsive or irresponsible. So these are kind of things that could set up a person to have a midlife crisis. And so what it is, and it's used in lay terms that someone's having a midlife crisis where there's a sudden and sort of acute change in behavior. They start to do things that are out of character, and it's defined as a midlife crisis. Emptiness syndrome is where kids have left the house, and so the nest is now empty. And so what happens here, are the parents quite distant? And you hear about parents getting a divorce after 30 or 40 years of marriage, as a result of this, where after that, kids have left, and now they're rediscovering themselves as a couple. Um, or, for example, dad is now retired and staying at home, kids are out of the house, and she has to deal with, him being at home after being away at work for God knows how many years. So, how does that impact relationships? So, other tasks, so men who reach maximum achievement by age 50 with no further challenges. So, by age 50, you're the CEO of one of, a major company. You have the money, you have the family. So, what next? Okay, so with having no further challenges, how does that impact mental health? Women whose identity was defined by motherhood, and now all their kids have left the house. So, and she's never invested in herself, or her social circle, or her employment, and now she's got nothing. And so another thing being a developmental crisis by age 50 or 55, when you feel like you cannot change an intolerable life structure. When you kind of come to that realization, some people don't, like, life goes on, but at the age of 50, 55, when you realize that, okay, your kids have left the house, so what am I? Who am I? And so how does that impact mental health? Late adulthood or old age. So it's a stage of life that starts at 65. So um, professions that deal with this age are either geriatric psychiatry or geriatric medicine. So it's the other end of the life spectrum, and so it's divided into two groups: the young old and the old old, or the well old and the sick old. And again, because like there's so much advancement in medical care, we're seeing a lot more healthy, older people, um, where people can now, like, live to 100. And so there's a huge need for people to specialize in this age group. So if anyone's thinking about like geriatric medicine or geriatric psychiatry, there's a lot of room to accommodate people in this, to work with this age group. So there's biology of aging, senescence, decline in function of organs, obviously not at the same rate, structural changes in cells, diseases of old age. Family history of longevity is the best indicator of long life. In some families, it's just, people live uh, long and healthy lives, but also a healthy lifestyle is really essential, and where leading causes of death being heart disease, cancer, and stroke, and how those are, becoming easily avoided given advancements in healthcare. Also, ethnicity and race, which can affect long life, sex ratio, where women tend to outlive men, And you see that phenomenon in nursing homes. Like if you visit a nursing home, you would see a lot more women than there are men. And how exercise, diet, and health can affect these as well. The psychosocial aspects of aging, interesting because how you know how socially integrated are is that elderly person, are they isolated, and what is the value of maintaining a social activities? Obviously it's so essential to continue having a social network, because the lifelong partner may pass, and if that person is not invested in some social connections, they become really isolated. Ageism, as coined by Butler, is a phenomenon where people discriminate towards elderly, where there are negative stereotypes about old age, where old age implies being lonely or having poor health or being senile or being weak. Now we're obviously seeing a major change in that, like with social media and a lot of older actors, actresses, influencers who look a lot well put together than people who are even 20 years younger. So we're seeing a change in that. Uh, how does the socioeconomic status affect mental health, retirement, sexual activity as well? There's a large percentage who remain sexually active. And then looking at long-term care, nursing homes, it's not really a phenomenon in this part of the world yet, because of how family structures are. Like we still have um, where the elderly are still well accommodated in their homes by their siblings or by their children. But we do see, I mean, it's called a vulnerable group, and we do see that there is abuse to the elderly, unfortunately, even if they are within their homes, abused by their children or spouses of their children. Yeah, so we do get cases in the hospital, as we do, for child abuse, we also get for elderly abuse. So with psychiatric issues, I mean, loss is a very predominant theme. Um, and how do they deal with grief? So, losing a partner of 50, 60, 70 years. And how does the surviving partner deal with grief, and the prevalence of major depression is also quite high because of illness. So we will see, depressive disorder in people with dementia, in people with Parkinson's disease, in people with stroke. So, we will see mental health issues for sure. Um, we're done now with, you know, behavioral the behavioral understanding of people across the lifespan, from we talked about from in utero until old age. And then again, as birth is the beginning, death would be the end of a life cycle. And so how do we understand death? How do we understand bereavement? So it's a whole science, to study dying and bereavement. And so looking at how do people react to death? Is death experienced as timely or untimely? Timely meaning expected, somebody with terminal cancer, or some terminal neurological disease, or was it an accident? Somebody who was well and healthy and who passed, can be thought of as intentional. Somebody who, takes their own life. Unintentional is somebody who engages in very high risk type behaviors. Sorry, meaning subintentional, or unintentional, somebody who died in an accident. So people who engage in substance abuse, risk taking health behaviors, are high risk for overdose, for example. So these are ways of understanding death. Um, Something that's also interesting is near-death experiences. So this is somebody who survives an accident. They were in a major accident and then they survived, or they're almost drowned and they survived. And so when you talk to these people, they'll tell you that they had an almost out-of-body experience, that it was quiet and peaceful, that they heard a distant noise, they felt like they were going through a dark tunnel, they witnessed beings of light. And usually people who've had these near-death experiences will then have major lifestyle changes. So after coming out of or surviving an accident or an almost drowning, people will, for example, donate, or they will, stop a lot of behaviors that were not good, the least to say. And so they start to become more focused on prayer, things like that. So it can provoke major lifestyle changes. Um, Kubler-Ross talk about 5 stages that a person goes through if they are told that they're going to die. Okay, so we see it a lot with cancer patients or people who have terminal disease. And so, you break bad news to them that they have, that many months before they will pass, given the natural course of the disease that they have. So the 5 stages that a person will go through um, are stage one is shock and denial. Okay. Then they go through a phase of anger. Um, and sometimes even angry with Allah, like, um, things like, why me? Then they go through a stage of bargaining where, they will say things like, if I just can live, then I'm going to do this, I'm going to do that, I'm going to change my life, I'm going to become a better person. Then they go through a phase of depression, um, where they realize that, it's going to happen, they become depressed. And then they go on to a stage of acceptance, that it is God's will and it's going to happen. Now, how long each takes is so variable. We usually get consulted at the stage for when people are depressed, they stop eating, low mood, they're tearful, their sleep is poor. So we are called in here. Usually in palliative care, it's a team. So with the medical part, the psychological part, but also there's a spiritual counselor that becomes involved to help with the acceptance part. And the spiritual sort of person, it really depends on the spiritual beliefs of the person, and what is their religion, and what are the religious beliefs based on that person's religion. So this is a very dynamic area, and there's people who are, specialized in working with patients, going through these phases to get them to the acceptance phase. Um, and again, it depends on what is their premorbid. Is this person someone who's never had a mental health issue and now is going through this, or is it someone who's, premorbidly has a depressive disorder or an anxiety disorder? And obviously, it's going to be very different in terms of how this will be processed. So attitudes towards death really vary across life cycle, and so if you have a 5-year-old, and how do they perceive death? And it's perceived like sleep. So a 5-year-old is going to think that someone who dies is just sleeping and they're going to wake up. But when they're a bit older, things become, there's a sense of inevitable mortality, thinking that you will never die. But then as they get older, there's a fear of parents dying. Okay. At age 9 or 10, they conceptualize death that it can happen to anyone. And then by puberty, they understand that it is irreversible and it is universal. Okay, so a teenager, their ability to understand death is very different from a 5-year-old. Okay. And so I get asked about that sometimes when you have a parent who dies, a father or mother, and so the family will ask, do I tell my five how do I tell my 5-year-old that their dad has passed? How do I tell my 3-year-old that their mother has passed? Okay. Do I take my 9-year-old to al maqbara to see their parents being buried? And so answers are going to really differ, obviously based on age, based on developmental abilities. And a lot of times I need to see the child, to really understand them, especially if they're older, like 9, 10, 11, 12, because your answers will differ depending on where they're at, developmentally. It's very difficult to treat dying adolescents. It's, I think, one of the most difficult areas when I get called in to see a teenager who has, a few months to live. Because adolescence is about being independent, it's about being oppositional. And then you have this adolescent who's, that's part of being who they are, now having to deal with, terminal illness or, cancer, even if it's treatable. We're seeing this 14-year-old who was recently diagnosed with leukemia, and she's really angry. She's an angry teen. Um, because right now she's refusing treatments. Her parents didn't tell her that she had cancer. And so she was given treatment because of an infection. They told her it was an infection, but then she's losing her hair. So again, it's really important to be honest with teenagers because they're not stupid. They're gonna, research, Google things. And so, if you start off by not telling them the truth, and that's very common, parents don't want to tell kids the truth because they don't want to hurt them, but, they end up hurting them anyways. With young adults, it's a fear of being of isolation that everybody's going to leave them because of their disease. Also middle-aged and older adults, how do they deal with death in terms of, their families and preparing their families for being without them, making out a will. So, so many things going into it, um, depending on where the person is in their life. Um, Grief is a subjective feeling that's precipitated by the death of a loved one. Okay. Mourning is the process by which grief is relieved. And bereavement is a state of being deprived of someone due to death. Now, the expression of grief is extremely wide. Okay, so there's a wide range of emotions, and it also depends on the cultural norms and expectations, and obviously on the circumstances of the loss. So in some cultures, it's 3 days of Aza. In some cultures, people wear black, and some people wear white. In some cultures, people, their expression is extremely excessive, and that's allowed or permitted. So again, it's very important when you're assessing someone or talking to someone is to understand what are their cultural norms. Um, Sometimes people uh, they kind of again vary in their reactions. I remember a patient was when her mom passed, she didn't cry. She was in Naza, no tears, and people thought that that was very odd. How could you not be falling apart when your mom passes? And that was something she was struggling with too. But again, months later, almost a year later, she fell apart. And her understanding was maybe I just had to be strong for everybody else, but now is my time to grieve. So again, it's so variable. But we have normal grief and we have abnormal grief. And that's important to kind of differentiate because interventions will differ. So, in normal grief, initially there's a state of shock, obviously, but that could be short-lived and followed by expressions of suffering, such as crying, feeling weak, not sleeping, not eating, and then dreaming of the person who passed. Um, Survival guilt happens when, you're in the same situation with the person who passed and then you survived. So like a car accident, for example, where, the person could be driving, but the one next to them is the one who died. And how guilty does that person feel, that they lost somebody and they were in the same situation. There could be denial. There could be illusions or hallucinations. I have a 7-year-old patient that I saw a few weeks ago whose sister committed suicide. And he only came to know of her death about a month before I started to see him. And he accidentally found out because in the past year since she passed, he was told that she traveled. He was 6 at the time. He was told that she traveled to complete her studies outside. And then a month ago, he found out that she passed. And so he, the complaint was that his parents were like, he's talking to himself. And so he just found out that she passed. And so when I saw him, he's like, I can see her, I can hear her. When I talk to her, I feel happy. So he's having this, and that's part of the normal grief, given his age and given he just found out. There's identification phenomena, so taking on the characteristics of the deceased, wearing their clothes, sitting in their chair, using their utensils, uh, kind of almost like walking like them or talking like them. So identification phenomena. So when someone that is close to a person passes away, uh, the normal grief it's like 4 stages. So in the first stage, it's acute despair, denial, and that lasts moment to days. Then there's intense longing, physical restlessness, can't sleep, can't eat, that can last months. Then there's a phase of disorganization with insomnia and weight loss, and then a phase of reorganization and where the deceased is internalized. So they'll tell you that, my father or my mother or whoever that passed that's close to me is with me forever, or I know that they can see me from above. They're with me all the time. So that sense of them being internalized, that they're going to be with them for forever. So the symptoms subside over time, and depending on the condition of death, if it's something that was, like an acute loss, like someone died in an accident, or um, they drowned, or they, sudden like death. We're hearing about. I mean, I'm hearing lately many cases where a person, a very healthy young person goes to sleep and doesn't wake up. So that is like. Very scary, scary situation. But traditionally, it lasts 6 months to a year. Okay, so that normal grief will last about 6 months to a year. And, the sooner a person gets back into their life, normal life, the better it is. And that's what I advise parents to children, get if they've lost, like this child who lost his sister, get them into normal activities quickly, make sure that they're consistently going to school because that's what's going to give them a better outcome. So acute grief subsides within 1 to 2 months. Usually then the grieving person can resume function. Anticipatory grief is when loss is inevitable, when you know that someone is going to pass. And so it occurs with the occurrence of anticipated loss and increases, decreases as expected. Loss becomes more imminent. Um, an abnormal grief is you have various forms ranging from absent, having no symptoms of grief or delayed, could be prolonged and associated with suicidal ideation or frank psychotic symptoms. So this makes it abnormal. People at risk of having or experiencing abnormal grief, if the loss is sudden or horrific, that the person was lost, for example, they were burned, or it was drowning. So if it's a horrific circumstance, if the person left behind is socially isolated, if they believe that they're responsible, if they've had history of traumatic losses in the past, and if they're very dependent on the lost one. Okay, so if the husband dies and she's been dependent, and it was, a horrific loss, and she's isolated, and that sets up that person to have abnormal grief. So if you have persistent low mood, um, with that's more in depression. Okay, shame and guilt are seen more in depression. Suicide threats are seen in depression. Okay. So somebody who's going through abnormal grief will have persistent low mood. So this is beyond, above and beyond grief. If they're feeling suicidal, that's above and beyond grief. And so here, it's not something that you're going to wait it out. If they're having psychotic symptoms, like I said, the 7-year-old who's seeing his sister, he knows that she's dead. So it's not that he believes she's alive. So if they're psychotic, meaning that there's no reality testing, so they believe that that person is still alive, they're suicidal. So this is abnormal grief and it requires intervention. Childhood grief. So a child who's lost a parent, or so Bowlby talks about a protest phase, a phase of despair, and a phase of detachment. Now, this detachment could be experienced by things like, they're not sleeping, they're not doing well at school. And so it's really important to focus on this phase to help them, kind of go back on track. And then lastly, parents who've lost a child are going to go through the 5 stages that were mentioned by Kubler-Ross. Okay. And I think that is our last slide for today.